There's my speaker. Hi, everybody. Good afternoon and happy 2023. I know we're off to a bit of a rainy, bumpy start, but really excited to see everyone join us today for our first PHAB meeting of the year. We're really excited. We have a great set of speakers today and just really excited to start off our 2023. I know folks are still joining, but I think we can at least get started. We don't have any voting items today because we were not able to finalize our December minutes for approval in January. So no need to check for a quorum at this point. But in the interim, we can start looking to the presentations. So just a couple of quick updates sort of from an administrative perspective. So for folks who don't know me, my name is Sanal. I have been part of PHAB since 2020, and I'm now one of the co-chairs alongside Libby Abbott, who's not able to join us this meeting. We're really happy to serve as co-chairs, taking over this role from Farla, and we know that we have some big, hardworking, super efficient shoes to fill as Farla leaves the chair role, but really grateful to continue to have her expertise to assist us during these meetings. Today's agenda includes speakers who are here to present on mobile health. It really reflects some of the feedback that we've taken into account since our August retreat, where we heard from PHAB members that we were interested in holding more panel-like conversations and hearing different perspectives on similar issues that are taking place in our county. So to meet this goal, we've included two sets of speakers, one set from Metro Fire and another set from Sac County, who are going to speak to mobile health and street medicine today. Before we start talking about that, we wanted to talk a little bit more about some of the other outcomes of our August retreat, including feedback from the group about talking about sort of the cadence of future meetings. What we learned back in August was that as part of this goal of creating more panel-like conversations and really deeper, like diving deeper into discussions of interest to the group that are sort of data-driven and driven by relevant public health issues that are taking place around us. It would also mean that we would sort of need to shift how we treat our other updates around like primary health and substance abuse and prevention treatment.
Hello. It sounds like you're trying to show the agenda.
Let's see. Stacy, I think we see a file folder and not the Word document with the agenda, if that's what you were aiming to show us.
Okay, Sonia, I'll share again and you let me know if you can see it.
Sounds good. Sorry about that.
It's okay. Can you see it now?
There we are. Yes.
All right.
Perfect. Thank you.
Sure.
So what you're going to see next month from Libby and I is sort of a draft schedule for the year of how we anticipate the year playing out with bi-monthly or every other month updates on primary health, adult correctional, public health, and so on. In those other off months, we're trying to develop sort of a speaker series similar to what you're going to see today. Moving on to the next thing on the list, which is about PHAB recruitment. As folks are aware, we have some vacancies that are due to people who termed out of their chairs. So one of the exciting things that Farla was able to do before she departed was work really closely with the public information officer at Sacramento County to develop a recruitment flyer. And that's the link that's on the page that Stacy is sharing. Please share that widely with friends, with colleagues, anyone you know who has an interest in public health who might want to participate in PHAB. We do have a couple of applicants and we're hoping to expand the pool in the coming months and just fill up all those vacancies that we have. So for today, we're really pleased to have some great speakers who are here to talk about mobile health, as I mentioned. First, we have Dr. Alex Schmalz, who is the director of Metro Fire, as well as Dr. Scott Perryman, who is the chief of Mobile Integrated Health. And they're here to talk today about mobile integrated health units. Our next presenters are Dr. Susmitha Mishra, a medical director at the Sac County Health Center, and Dr. M.K. Orsalak, who's a UC Davis physician and homeless and street medicine doctor. And they're here today to talk to us a little bit more about the county's mobile health and street medicine teams. So we're going to give them a chance to present some information about their group, kind of what they've been working on, some updates, challenges and then ways in which the PHAB can work with them to further their goals and see in which ways we might be able to either partner or collaborate in the future. We've also left some time at the end of both presentations to address any questions that folks have. Dr. Schmalz and Perryman, if you are ready, you guys can get started. And then, as I mentioned, you have co-host ability, so you can share your screen and move through the slides at a tempo that kind of works for you.
I don't know if they have co-host ability. Unfortunately, the way Nick sent this over, I had to log in, so I don't have control over that.
Okay.
So sorry. If you want to send me the presentations really quick, I'll pull them up. Otherwise, I'm not sure what to do because I cannot make anyone a co-host.
No worries. So actually, I think
they can try and see if they're able to share.
So I just tried on my side. It says that I'm not able to share a screen while some other person is sharing their screen.
Okay, try again, see if that works.
Right. I believe it's going to work.
Yay.
Amazing. Thank you all.
All right. Well, is it looking like it's working?
Looks great.
Okay, perfect. I am not a computer person at all, and anybody that knows me understands that computers and me don't necessarily like each other sometimes. So, first of all, I just want to thank you guys so much for the opportunity to be able to share with you what Metro Fire has done with mobile integrated health in this Sacramento region. There's a lot to talk about, so I'll try to condense it and make it worth your time. The first thing is just kind of talk a little bit about the EMS system. So when somebody calls 911, as a paramedic, I only have two options. Those options are either take you to the emergency room, or the worst option is you just stay there on scene and you kind of figure it out on your own. So as paramedics, we only have one option, and that's to take you to the hospital, and that's just to the emergency room. And you would think that you'd be able to correct that by allowing us to go to urgent cares, but then insurance gets involved and it gets to be pretty dicey. And so as the fire department, we kind of only have one source, and that's kind of like a big old hammer. We take this hammer and we take everybody to the emergency room, and that's it. And so after a while, when all you have is a hammer, your arms, they tend to get sore. And so this kind of points out is all we have is just that big old one sledgehammer. So what did we do? Well, we realized that wasn't the only option. So we started looking at other things, and that's where mobile integrated health kind of popped up. And so what we did is we talked with a lot of different areas or resources in the Sacramento area, looked at what was specifically needed and how we could actually be a benefit to the system. Because again, not every person needs to go to the emergency room by ambulance. So we came up with mobile integrated health for the Sacramento area, and we came up with objectives. Some of those objectives were, to deal with the high utilizers of 911. The second one was to deal with some of the low acuity 911 incidents, and then also to deal with some of the psychiatric components here in the Sacramento area. You can see kind of our overall objectives, and that's to kind of make it better for everybody, reduce the hospital admissions, and to reduce the cost of everything. And so that's what we did. We designed this program. We got funding for a year, and we're so excited to start. And then we realized that life is full of surprises. And that's exactly what happened here. Just kind of like a fish to the face, nobody expected COVID. And that's exactly what happened to us. While our program was getting ready to launch, COVID came and hit us out of nowhere. We were not expecting it. What was beautiful about this is mobile integrated health was getting ready and moving forward, and Sacramento County had some issues. They realized that not everybody could go through some of their mass testing abilities, and that they had congregate living centers, mental health facilities, incarcerated individuals, homelessness. There were a lot of issues that just couldn't go through some of their big testing centers. And that's where mobile integrated health was a fantastic fit. So we were able to have advanced providers, nurse practitioners or physician's assistants paired up with our amazing firefighter paramedics, and we went out into the community where it was needed. We went into those congregate living centers, the ones that were identified by public health, and they said, we need you to test this. So what we did is we provided that testing. We did an amazing job. We did 4,600 tests in about 3 months. And then the county realized how important it was, so they kept us going. And we were also able to help out the public safety, the police officers, firefighters, and keep them making sure that those who were exposed or were symptomatic, we could identify those who were an issue. So we did a lot of testing. What did all that testing do? Like, what does it mean? Well, this graph right here and this data kind of shows that. What it shows and what it means is that we started on the left-hand side, the figures 1 and figures 3 show what mobile integrated health did. We went into some of the most vulnerable of the population of Sacramento County, and we're able to test. We're able to identify those individuals, and we're able to get those on the radar of public health, so that way they can provide correct treatment and resources where they need it. And you can see in the figure 1 and 3, you can see that it starts off fairly high and then it dives down. And the reason why is because we were able to identify, and then we provided serial testing so we can make sure that those who were symptomatic, that we were able to isolate them and not get the rest of the congregate living centers infected. And then now you can see the direct contrast of the figures on 2 and 4, where the rest of the county started to spike. That's because they didn't have some of the same opportunities that MIH was able to provide. So MIH really provided an amazing opportunity for a lot of folks. One, we were able to deliver care to, to those out in those places that couldn't get into that mass testing. Just a simple example is there was a nursing home. They were hit pretty hard with COVID. They called our MIH unit and they said, we're taking 12 people to the emergency room unless you can tell us otherwise. MIH was there within the hour. We were able to identify those who were ill and those that could stay in place. That meant 12 individuals would have gone to the emergency room, taking up beds and other resources. Instead, only one person needed to be transported. We were able to keep them there at the scene. We were able to provide them correct care, and we were able to do further testing to identify those that needed to be isolated. That was just one simple example, and it worked very, very well. Well, after the COVID situation the emergent issue had kind of slowed down, we were able to get ready for the actual start of the design of mobile integrated health. So November 2015, we launched the program working on our high utilizers of 911. That's what we were able to do. So we worked with our high utilizers of 911, and we had something amazing happen. And this is what it was. What did we do? Well, this is what we did. We worked with high utilizers. We saw a 43% reduction in their 911 use. Now, these individuals are some of the most challenging patients. They call 911 often. They go from system to system to system. They fall through the gaps. And we're able to reduce their 911 use by over 43%, which is very, very significant. And I'm going to talk a little bit about that more. But I wanted to, in this slide, you can see that we were allowed in the 911 system, and we weren't allowed in the 911 system until later on in the year, until around September. And that's just because we wanted to work with the county, and we want to make sure everything was in place so that we didn't have any bad outcomes. Once we were allowed in the 911 system, for this time period that we were actually capturing the data, we only had 20 911 calls, which we know is low. But as far as when we're allowed in the system, we're actually making some good progress. 85% of the time, we were able to treat and release the individual on scene. That meant that they didn't tie up an ambulance. That meant they didn't tie up an emergency room. That meant that they were able to stay in the comfort of their home or wherever they were. It works out phenomenally. And then, of course, that was over $1 million in savings that we were able to directly attribute. We knew how much the ambulance ride was. We were able to compare it with the data that the hospital was able to provide for us. So we know we saved over $1 million. And this isn't even accounting for the psychiatric patients that we're able to divert from the emergency room and directly admitted into a psychiatric facility. So there's just been some great things. So when I look at the numbers, the way I see it, is we are just getting started. I've been able to talk to other systems that are doing similar projects, and the first year, and then now a few years later, they've seen quadruple the amount, which means obviously substantial savings, but it's about the patients. And so the numbers are numbers. I want to talk a little bit more about the individuals because that's where it really matters. There was an individual who is on hospice, and this one was a little near and dear to my heart because I was able to witness this firsthand. This individual was on hospice. He's on end-stage care because of some prostate issues. He normally does a self-catheterization to relieve his bladder. Because he'd grown so weak, he was unable to do that. He called his hospice nurses. They were 6 hours out at minimum because of other issues. Family did not know what to do. And so they did what they know they can do. They call 911 and they know that we're going to be there. So we showed up, and our 911 crew realized that this would be a perfect case for our mobile integrated health unit. And so they called the mobile integrated health. We went out there. We were there within minutes. We were able to do the procedure for him. We were able to give him a little bit of dignity, keep him in his home. He didn't have to go to the emergency room and sit on an ambulance gurney and then the hospital gurney for hours and then have the procedure and then return back home, which who knows how long, how many resources, and at what cost. We're able to do the procedure in his home and provide a little bit of dignity, change him, put him in a fresh pair of clothes, talk to his family, and then follow up with the hospice nurses and let them know that this is what we've done. And they were able to tell us that they're going to be there within a few hours. It was an amazing story that it just worked out well. There's another individual that we got a chance to work with. This individual has a very significant psychiatric history and visits the emergency rooms often. You can imagine with the significant psychiatric history, they're not able to drive. They don't have a job. And following directions on getting on this bus, going across town, and then getting on this bus to get to this appointment at this time, it can be very, very challenging. It worked out well when we worked with the health system. We got the injectable long-acting antipsychotic. We were able to bring it to the individual and give that medication to them in the field. It works out well there. Another situation, one more that I'll just bring up quickly, is there's an individual who called 911 because they simply needed a medication refill. They lived out of state. They moved back to California, and they were kind of in crisis mode for kind of depression, a few other psychiatric issues. They just simply needed some of their medication. We were able to refill that medication. We were able to follow up and find out what insurance they had, get them connected with a primary care provider, and that is how we wanted it to be. We were able to provide immediate issues where the ambulance didn't need to be there. They didn't need to go to the emergency room. They just simply needed some medication refills and directed to the correct sources. There's so many stories that I could share of individuals that we've helped. The individual that's called 911 20 times in 6 months because they have severe diabetes, because they keep injecting themselves with the wrong medication, because they're colorblind and they can't see which medication that they have. Is this one fast acting or long acting? We're able to go there and provide education. Okay, this one is your short acting, this one's your long acting. And to see that 911 use just absolutely plummet. There's so many stories. These are all individuals that fall through the cracks. They go to multiple hospitals, they call 911, and the ambulance in the emergency room isn't necessarily the best fit. A lot of the time, the primary care provider has no idea what's going on. We found individuals who fall multiple times, and they never go to the hospital because they just need a lift assist. And that's what the fire department does. But then the healthcare system has no idea. That's where we came into play because we knew that they're a high utilizer of 911 and to be able to provide those resources. So all about these individuals falling through the cracks. But what was the cost? What was the cost of all these things that we did? We had a projected budget of a little over 1.1 million that was graciously donated to us. Well, we spent about 600,000 after the year's process. We realized that the system costs about 700,000 a year to run. We have a remaining budget over 500,000 right now. That's going to get us over the next few months, which is we're very pleased to announce, because what we thought was only going to be a year-long budget, we're able to stretch it over a year and a half. So what does that mean from here? What are some of the areas we can grow? We noticed that the low acuity 911 calls, there's a significant amount, over 18,000, and it's growing yearly. Some of these examples of low acuity issues are medication refills, blisters, sunburns, lots of these things that don't have to go to the emergency room. But again, in the EMS system, I've got that big hammer. All I can do is take you to the emergency room or you stay on scene. With mobile integrated health, we can fix those things without taking up resources at the ambulance side, the emergency room side, and we connect them back in with their primary care provider. Another issue that we've seen is a dramatic increase in the amount of overdoses, specifically opioid overdoses. And you can see where there's a pretty significant increase in the amount of opioid overdoses within Sacramento's jurisdiction. Those are areas that most of our providers have the X waiver clearance where we can do some of the advanced treatments in the field. We know where some of these individuals are. We can meet them where they're at instead of making them come to us, missing potential opportunities. So this path kind of shows that there's no wrong door. There's so many different opportunities that we can move into. We're dealing with the high utilizers. We're working on the low acuity 911 calls. We're starting to make some good pathways with the psychiatric care, getting patients medically cleared and directed to the psychiatric facilities. There's lots of opportunities, and we're looking at what does Sacramento County need, and that's what we're wanting to do. Is Narcan, is the homelessness group the area? We have things that we've identified, but we're also open to new opportunities. And so we look at what does the future lie ahead for mobile integrated health? What does it look like? Well, I mentioned earlier that we only have a few months worth of funding left. The big thing that we have is we know we have this funding. It's going to take a little bit of time to get new MOUs and things in process. We need some more funding, and that's our ask today. We know the program takes about $700,000 a year to run, and we know our numbers are going to exponentially increase, so we're making a bigger impact. But I always feel like one of the biggest things is I don't want to have to come to any advisory board or any panel that has potential funding opportunities and ask year after year after year for a handout. That's why I'm excited about this, because there is potential funding mechanisms that are working through the system. They're just going to take a little bit of time. And so that's why we're asking for funding to help get us through until those funding mechanisms can be definitively placed. And then the burden is no longer on the county. It can be placed where it needs to belong. So there's so many opportunities that mobile integrated health has been a potential for, and how it's already been an impact, but it also works out well with the existing systems that are in play, working with public health, behavioral health. And then also there's so many great things that are already kind of in the process. You're going to hear very soon about another mobile integrated health program. Our program is designed to take care of the more emergent matters and then to pass it off on to those who are in more of the primary care and who can do more of the lasting stuff. But we have the data and we have the knowledge that a lot of people aren't aware of. A lot of those high utilizer visits, a lot of the lift assists, and just people falling through the gap. I'm really proud of what we've been able to accomplish so far. And I think that's what I wanted to share for now. I wanted to give Dr. Schmaltz a little bit of time to clean up anything that I missed. And then obviously we'll open it up to some questions. So Dr. Schmaltz, it's all yours.
Awesome. Thanks, Scott. Do you mind going back to that last slide? You did a wonderful job presenting that. I know it's impossible to kind of put all of the hard work that you and the rest of the team have done over the last couple of years into a 20-minute presentation. So I'm looking forward to answering any questions, but I think one of the big takeaways is that I think we've really just started to get going on this. Scott and the rest of the team have put endless amounts of time into establishing this wonderful system of having 5 mid-level providers, PAs and NPs that are able to respond, 5 days a week, 12-hour days, and really help provide better care for patients in the field, better utilizing our resources as a community. As you can see from this chart, we've really only established 2 pathways thus far. And I think that there is so much more potential that we're already working on and that we're hoping to better serve the community through, and while growing the pathways that we've already established. As Scott mentioned, most of these programs see a quadrupling or so of their volume or the patients that they serve within, from first year 1 to year 2. A lot of those have seen more, but we're also working on, trying to solve some of the root causes of inequities and health problems in our healthcare system. So, for example, we're working with the California Bridge Grants or the Bridge Program to try and set up a really innovative and, I think, frankly, exciting way to help treat substance use in the field. It's kind of a 4-pronged approach of giving people Narcan, helping have a substance use navigator attached with the mobile integrated health unit, who can help navigate people into outpatient clinics and follow-up appointments. We've already created a linkage with some outpatient follow-up substance use programs to kind of help with patients that we'll be treating in the field. We'd also be able to give people buprenorphine in the field or Suboxone in the field, and then set them up with a 2-week prescription while they navigate the process of getting into their outpatient treatment. As Scott mentioned, we've really been mostly kind of navigating off of referrals in from our medics rather than having the medics or have the 911 system kind of route us directly. And then we're also kind of building up our psychiatric clearance and treatment in the fields, as well as our connections with the people who are helping out with the unhoused communities in Sacramento, which, as we all know, is a massive area that we can improve on. I think one of the biggest things to take away is how this is a much more the numbers are, I kind of think, speak for themselves. It's the compassion and the humanity of the program that really resonates with me, and I think is the most powerful part of this. And I'm always blown away by our providers and the work that they do and the spirit in which they do it. And I think that we've created something that's already speaking volumes and kind of speaks for itself. But it'd be an absolute shame to have this resource be lost to the community. And that's why we're looking for a couple of years worth of funding to help kind of tide us over until we're able to get more sustainable kind of C3 funding or other pathways of funding as we go along. So thank you very much for your time. And if you have any questions, we're here for you.
Thank you so much. This is really exciting. And just kind of hearing about some of the work that's being done out in the field and some of the new and innovative ways in which we're looking at helping people, frankly. Looks like we have a couple of questions. I just want to start with those. The first one is from Melinda. Is your program interfacing with 988 as well?
It's not currently integrated with 988. Again, it makes it a little more difficult because this is Sac Metro's area. So it's the short answer is it's not.
Okay. And then, sorry, just to expand on that, when you say this is Sac Metro's area, can you kind of elaborate a little? What does that scope kind of look like? Is it 911 calls that referrals come through medics? You mentioned those referrals, or is there some kind of triaging happening with the 911 system?
Yeah, so what happens is when we first started, we looked at Metro Fire's data, which is Sac Metro's jurisdiction. So we don't have access to Sacramento City, Folsom, Consumnes. We don't have access to them. So we only looked at Sac Metro's area, and we saw those who are calling 911 often. And then we also got referrals from the crews if they saw something significant before they became a high utilizer, more kind of a proactive response. And then it was later in September that we were able to get into the 911 system. And that was working with our local EMS agency and making sure that everything was correct before we went into the system. What I mean by in the system, it allowed crews or fire engines to be able to request us specifically. So we're not automatically dispatched. We have to wait for crews to request us on medication refills, simple lacerations, things that we can work on. And that's why the numbers are so low, but they are increasing because now the crews understand what they can call us for and what they can't. So those are the main areas that we've been working on and so far. And that's how the call system kind of comes down. It comes from either crew referrals, our own internal data, and then on the 911 side, it comes from engine companies or truck companies that are on scene, and they realize that the patient meets certain criteria, and then they can request us.
And we did have, correct me if I'm wrong, Scott, but I think we did have a fair amount of outside referrals too from, like Kaiser and other places, other hospital systems that noted high utilizers, or people who were disproportionately utilizing the system. And we were able to kind of do some intensive, like social work, case management, that kind of stuff, and as well as treating them in the field with the program that we have set up too. So it wasn't just through the 911 system, it was more of a community, or there's definitely a community aspect to it as well. And that's always something we're looking to grow too.
And Lynn, I know you had sort of a similar question. Does that address all parts of your question, or was there anything in there missing?
Thanks so much. Yeah, as it was happening, I was like, oh, check. This is great. So I also do want to know more directly if this is only through 911. You did answer that in some ways, but is there another way to request your service?
We, like Dr. Schmaltz was saying, we did get requests from different health organizations like Sutter and Kaiser. They would be able to reach out to us. And so, yeah, there was a pathway for that to happen.
But not from the general public.
Not from the general public.
Okay,
Correct.
thank you.
The next question comes from George, and I think this is more of a question for us. He points out that we are not funders, and that's correct. So what is FAB's role? Do we recommend funding? So normally, and then just for everyone's awareness, we take up these issues, so we'll continue to discuss them. And one approach that we might take is to submit a letter to the Board of Supervisors recommending or advising that perhaps this is a program that they might be interested in funding for the future. So George is correct, we are not funders, but we take this information and then potentially in our advisory capacity advise the Board of Supervisors that this might be a program that they might want to put some money in. So we appreciate some of the information on. It sounds like there are some future funding opportunities that would not rely on county funding, but in the interim to continue to develop and maintain the program at least the level you're currently supporting the community, and there would be some sort of bridge funding needed. So George, hopefully that kind of answers your question there. Dr. Kasiri, I see your hand was up at some point.
Yes, it's kind of hard to see, but I just wanted to point out that I still have it up. Thank you. I'll keep my comments brief, but I did want to mention again how appreciative we are of the assistance that we got, especially during the early stages of the COVID response. With the long-term care facilities. At one point, they had to do serial testing, sometimes twice a week, sometimes weekly, and they did not have the resources to do this. So having the teams go out to the facilities helped us a lot, especially when we were having a lot of outbreaks in those facilities. And we constantly heard from the long-term care facilities telling us how grateful they were, because this wasn't a resource that was available in every single county. So for us to have it was really helpful. I was glad to see on your list of areas of focus that you do have the surge response and pandemic on that, because, you know, we always have to be prepared. And what the thought that came to my mind actually was the recent surge that we've gone through with the RSVs, where we were having a lot of pediatric cases that were not able to get to the ED because the EDs were completely full. And I would love to be able to work with you all to see, of course, now I think the pressure's off, but to work out a process similar to what we had during COVID, where we would be able to recruit you as a resource for situations like that, because we were talking to the medical directors of the pediatric hospitals, and they were all saying, what resource can you give to us? And we really didn't have one. So I think this is an area that we can work on. I don't know if you have any pediatricians on your teams, but I think it would be great to have something that a process that we can work on for situations like this. And I just wanted to point out also that you do have our director, Tim Lutz, on the call. So in terms of what George was asking about funding, you can make your request directly to him.
No pressure on that, Dr. K, but thank you. And yes, I am taking notes, and I appreciate getting to see this program because I've heard a lot about it, and it's nice to see Scott and the presentation, because I think it is, when we look at the EMS system and how do we provide better diversion to our emergency rooms. I love the question on crisis and 988, and I think as we hopefully continue to see this model build out, that's where we can see more of those linkages and nexuses with other programs. So I think what you presented here is those first steps of, all right, how do we continue to build this model to make it sustainable, and then start to build on top of that to actually bring in new services to it.
Yeah, all great points. I wanted to go back to Dr. Kasiria's points of, the pediatric surge. I mostly work in Southern Sacramento, and I felt that surge very palpably. As we would have 50 to 60 families in the waiting room. And most of them were just waiting for RSV tests, to be entirely honest. So it'd be, a very low hanging fruits to set up something similar to that at some point. If Scott probably has more thoughts on the operational level, but that would, I think, accomplish all of our objectives of helping divert care. And if people called into 911 and were like, hey, we just wanted a COVID test or an RSV test or things like that, I think we'd be very open to collaboration, because that'd be a great way to serve the community. And I know from experience that I was seeing 50 kids on a 8-hour shift, which is just, it's not safe. And I think 30 of those kids were probably just coming in for tests. And so you weren't really able to provide care to the 20 actually sick kids. And so if there's ways to offload some of that, I think we could provide a lot better care to a lot of patients, better serve our community. And I think there's always a modicum of adaptation that's going to go with every surge, because if we could predict every surge, we wouldn't be a surge, right? We'd be ready.
Did we lose him?
I think we might have lost him. Uh-oh.
Um,
That's okay. I think we have 2 more questions, and we can certainly take more at the end. And Dr. Perriman, if you feel like you can respond to these, or if we should wait for Dr. Schmalz, that's fine too. The 2 outstanding questions, one from George: is this being done elsewhere? There must be ways that your team can show sort of the efficacy and effectiveness of the work you've been doing via data, to show the others that you can save money doing this work.
Yeah, no, so the great question. I would love to say that Metro Fire is the one that initiated it, but it actually started in Mesa, Arizona, where they actually were having an influenza pandemic. And because of it, they closed down one of their hospitals because it was just so intense. And they transported those patients to other hospitals, and they said, what are we going to do to make sure this never happens again? And that was the birth of Mobile Integrated Health in Mesa, Arizona. And then it moved on to other areas, California based. It started in Anaheim, and then you've got LA City. I've gotten a chance to see their program often, and then LA County, and then also San Francisco. We've been able to talk often, and what it all comes down to is a lot of the payers are very interested because they realize the cost savings to it. It's just they need time to get one. They wanted data. Of course, they wanted data, and now they want several years of data to make sure it wasn't just a fluke. And then now there's the building of the mechanism to be able to get the cost recovery. Again, like I said, I love this program because I don't want to ask for handouts for eternity. I want it to be able to be, we just need enough to get through until it can be sustainable. So yeah, we are working with LA City, LA County, San Francisco, Beverly Hills, all similar programs, but it's also specific for their area needs. You can imagine Beverly Hills, very, very different than the needs of LA City. So overall program, it works really well, and they get to cater it to their specific needs. And once we have a little bit of time, then there will be sustainable funding.
Then I think they'll take this question and then we'll take any others at the end. Melinda asks, where does SAC Metro cover? What area does SAC Metro cover?
Oh gosh, so we cover the areas of, let's go with like Rio Linda, Antelope, North Highlands, Citrus Heights, Rancho Cordova, Rancho Marietta, and some South Sacramento area, and then Arden Arcade. Those are the big ones that kind of come to my mind. I know I may be leaving out a few others, and I apologize for that, but those are the ones just kind of shooting from the hip real big. So
I think we cover more area throughout the county than any other fire district or department, because we were an accumulation of 16 different fire departments over time. So we are the biggest coverage area, I think, throughout the county. Correct me if I'm wrong, Scott. But.
Correct.
Well, thank you so very much for sharing and also just staying on to answer questions. We'll shift over now to our colleagues from Sacramento County, Dr. Orsolak and Dr. Mishra, who are going to present on mobile health as well as the street team.
Can everyone hear me?
Yes.
Okay. All right. Before I share my screen, number one, thank you everyone for the invitation to speak. So I'm Sumi Mishra, the medical director of the Sacramento County Health Center. So we're part of the primary health department, and I'm joined by Dr. MK Ursulak. And she is faculty at UC Davis, Department of Family Medicine, provides family medicine services at our brick and mortar clinic here, as well as our Loaves and Fishes clinic, and is going to be one of our street medicine providers. So before I launch into our street medicine presentation, which is what we haven't officially launched, we're going to very soon. I just wanted to give like a 2-minute background on our homeless services for those of you who haven't been around forever like me. But our focus is the homeless. And so for many, many years, when we were CMISP, County Medically Indigent Services Program, we had a federal grant to take care of the homeless. And so we had a full service homeless site over at Loaves and Fishes with a provider doing full scope care along with the nurse. Times changed, recession happened, a lot of things, managed care came into the to the forefront. And so we sort of stopped everything and we just had a nurse out there providing navigation and sort of transportation and TB services. And then fast forward, 2020 came along and some of the providers management thought, well, you know what, it's time to, this is the pandemic. We need to do more for this population. And so we worked with Loaves and Fishes and started back our primary health services over in a different location, but still within the Loaves and Fishes Park at the Delaney Center. So there we provide full scope services 5 days a week. And then in 2021, with a grant from HRSA, we got a mobile unit and began our mobile services in the parking lot just to get our feet wet. And amazingly, a lot of people show up to the van when they don't come to the to our clinic. That's pretty, it's still striking to me that people will come there as opposed to going to a van. And now, hopefully very soon in the next month, we're going to start up our street medicine services. So I just wanted to share that information. It's been sort of a progressive thing that we're able to do for this population. So let me see if and MK, I don't know if you wanted to introduce yourself officially. We'll be sharing the presentation, but feel free to say something while I launch the presentation.
Yeah, no, just happy to be here with everybody. And I think you gave a good introduction, but it is exciting to be at this stage where we are going from kind of the brick and mortar at Loaves and Fishes to the launching the street medicine aspect of this. And so I'm very excited.
So is everyone able to see what I'm presenting? Okay, cool. So that's me, and that's Dr. Ursulak. So our objectives today, who are we, who's the street medicine team? We'll go over the missions and goals, what we're currently doing and what we're hoping to launch very soon, who we're collaborating with, and some of our challenges and the solutions we're seeking. So our primary health, mobile, and street medicine team, we collaborate with UC Davis, so Dr. Ursulak, who's on the screen today, and Dr. Landefeld are going to be our street medicine providers. We are working very closely with County Public Health, and so a medical assistant, Rachel Reed, is also part of our mobile service team. And we will soon have a care management nurse, a public health aide working alongside with us. And I mentioned our public health team. So currently what is happening is we take our mobile unit out with the provider, the medical assistant, soon to be our nurse and perhaps aide. And then at the same time, public health brings out their van. We're a mobile medical van with medical exams in it. Public health brings out their van with their staff, which currently is a communicable disease investigator, a CDI, and I think a linkage person. So we meet and then we collaborate in our services. So so we are working together. Primary health is working together with public health and providing the mobile and street and hopefully street medicine services. So at our brick and mortar clinic, there are more of us working. Dr. Ursulak, Dr. Landefeld, and a couple of other UC Davis providers. I'm out there on Wednesdays. We have a public health nurse, and we also collaborate with Sac County Behavioral Health to have a substance use and prevention treatment counselor, Alex, who also comes out there on Wednesdays. So we're there half a day, every day, Monday through Friday at the brick and mortar clinic. And I should also mention that Dr. Robitz is family medicine psychiatry, who's out there on Tuesday. So we also offer psychiatry services. So that's our mission, to partner with community organizations to bring comprehensive, low barrier, compassionate healthcare to the people living in encampments in Sacramento County. Our goals are listed out there, certainly to reduce the inequities in health services among people experiencing homelessness, partner with community and governmental organizations, and hopefully provide evidence-based substance use disorder treatment. This is our van. If anybody's been in our parking lot at Sac County Health Center, it's parked there, and we take it out in the mornings. It's I'm biased, but I think it's very nice looking and it's kind of cool. So come by and visit it. And actually, I'm going to turn it over to you, MK, to talk about the services.
Yeah, wonderful. So like Dr. Mishra said, right now we are operating out of the van in the Loaves and Fishes parking lot, and I'm doing a broad range of services, mostly a lot of acute care evaluations and urgent care visits with lots of different things right now, from coughs to shortness of breath to heart failure to cellulitis. So a broad range of kind of one-time visits for an acute thing. And because we are there regularly and consistently, we're able to do longitudinal primary care visits for people who are living close by in the area, or I mean, really for anyone, but most of the people who are our longitudinal patients are people who are close by who will see us for multiple things. We have an incredible team, including our nurse Eileen. So we do a lot of wound care, and so she's there 5 days a week. So she's able to see people consistently and do consistent wound care for folks to help with that. And like Dr. Mishra mentioned, we partner with the Sacramento County public health team and do rapid, so immediate HIV, hepatitis C, and syphilis testing. So those are results that come back within 20 minutes, so people can get their testing and results there, and if positive, are connected into care. And then also multi-site gonorrhea and chlamydia testing. We also do TB testing and the TB cards, which are required for some of the shelter places, and immunizations, which is great, and then medication storage. So we are able to provide medicines, and we could talk a little bit more about this maybe, but this is kind of one of the things that is continuously evolving and growing. But right now we are able to provide some medications on site at our Loaves and Fishes brick and mortar location, but we are able to send prescriptions to pharmacies for any patients we see. And yeah, the future is exciting and bright. As mentioned, we are planning soon to launch and go out into encampments, so provide direct care to people who are experiencing homelessness at different sites. And ultimately, so right now we are operating 2 half days a week with Dr. Landefeld and myself, but the goal is to continue to increase the number of street medicine service days so we can continue to provide care for folks. Lots of things, lots of exciting things with CalAIM and those aspects. And so our goal is to start linking to people to enhance care management and community support services. And then continue to partner with our county, our city, and the community organizations who are doing so much work with encampments and with folks outside, and to continue to build partnerships to be able to provide care and services through those partnerships. Yeah, that's what it looks like inside. It's really nice. There's 2 full functioning exam rooms, and yeah, it's kind of a small clinic room. Great. I'll pass it back to Dr. Mishra.
So thanks, Impey. As I mentioned, we're partnering with UC Davis, and obviously we have an amazing team of UC Davis clinicians, and I'm county, we're county, so we're all sort of working together here, county primary health, but hoping that we can broaden our collaboration with behavioral health and their heart team, community-based organizations. I forgot to mention that we have an agreement with SAC Covered already. They come to our main primary care center twice, actually 4 days a week. So they provide transportation, linkage, interpreter services, food assistance, all kinds of things. And one of the navigator comes out on Friday mornings to our Loaves and Fishes clinic. So we're hoping to just expand our collaboration with them and see how we can work further in our street medicine work. Perhaps, using them to do the linkage to ECM. They themselves are an ECM provider. And so just looking forward to working with them a little bit more. County has created the Office of Homeless Initiative Department, and there's lots of work happening there. So really trying to tie in what we do to what they do and what's happening over there. There's other street medicine providers out there. There's Alec. I know that WellSpace, they're on a hold a little bit right now, but I'm hoping that maybe we could even potentially collaborate with them. So I think that that's been the challenge, because there are so many people who are interested, which is great, right? We all want to be able to serve this population and do the work, but we're working in silos. I think there's several different people who are in organizations who are doing something, and we just don't know what each other are doing. And so we need to figure out a way that we're all talking, and this is one great way to do that. So I'm hoping that that there is maybe a little, we're looking to see how we can partner better and know what each other is doing and collaborate further, so that there's not too much duplication, but that also isn't necessarily a bad thing, right? And then the other challenge is the billing and funding. So technically, as a federally qualified health center, patients are assigned to you, and so then we can bill and get reimbursed for those services. But as you know, with this population, they may be uninsured or they're assigned elsewhere. They may have insurance in Nevada or Florida, Oregon. We see all kinds of things. We're not going to not serve them. We're going to serve everyone, right? And so that's been the big challenge is then how do you sustain a program? I know with this all plan letter from the state, I think that it's such a great thing that's happening. So hopefully that will be a route to be able to bill and receive funding reimbursement for these services. So so we're holding our breath, and I know we all have a voice in that. And so looking forward to hearing more about that. Opportunities and solutions, it's some of the same that I've already mentioned is to enhance our relationship with our sister program at Public Health. I know and talk to UC Davis a little bit further, continue to meet and talk to other organizations out there and see where we can partner, merge, or link our services. So that's really all that I had, short and sweet. And Dr. Ursulak, Dr. Landefeld, and I are going to be talking very shortly about where we want to actually launch and take our street medicine services. And so finalizing the locations. So that should occur in the next few weeks. And just some contact information. So that's it.
Thanks so much, Dr. Mishra and Dr. Ursulak. It sounds like amazing work is being done, especially around the Loaves and Fishes area and just across that county to help those who are currently unhoused or in need of medical services. We have a number of questions, and I realize I don't actually need to read them. So if folks would like to just speak their questions aloud, that would be wonderful. George, it looks like you have the first one, and you might have a couple of questions in there if you'd like to just say them aloud.
Yeah, I had two questions. Is it possible to put a team out on the street to help sign up the homeless for Medi-Cal and or Medicare? And that's the first question I had. Let's see if I can find the other one. And the other one was, if you're looking for volunteer providers, you might reach out to the Sierra Sacramento Valley Medical Society Spirit program. They may be able to help.
Yeah, and so that's where we're hoping to partner further with our SAC covered navigator, because that's exactly what Emily does for us, both here at the clinic as well at Loaves and Fishes, is that she signs up patients for, she sees what they qualify for and signs them up for Medi-Cal and Medicare. Do we bring her or another navigator there, or do we just work with SAC covered and have them meet us out to wherever we're going to go? So that is the goal, to have someone help with signing up for healthcare coverage. Providers, yeah, exactly. We're thinking about, I'm strategizing on all different ways to make this happen. UC Davis School of Nursing got a grant to improve access to just the Medi-Cal population as a whole. And so I'm working with them to see how we can, is there some area, something within the world of street medicine that we can partner with? Of course, we have our refugee program. So I'm looking at everything. So we may partner with them. But we have a close relationship with Spirit. They provide volunteer specialists here at the clinic. And so, yes, they're a great resource.
And Farla, I think you have the next question.
Hi, thank you very much. This sounds so exciting. The work is amazing. I was wondering whether you were at capacity with the supplies and personnel and everything that you've been supplying to specifically loaves and fishes, but actually all over. So the question is really, what do you need? Do you find that the need is greater than what you can provide?
Well, right now is and MK, as you can answer also, but right now we are only able to offer 2 half days a week, right? And that's we'd love to be it as far as our mobile team, and that's eventually going to go out to do street medicine. So we'd love to have it be every day or increase that. As far just speaking of our clinic out at Loaves and Fishes, we are sort of limited by the space. It's a small location, but we do amazing things there. And so we have a nurse and a provider and a psychiatrist on some days, and the SUPT counselor. So we kind of maxed out on space, but I think that as far as street medicine, when we go out, right, we're not limited by that. And really, however, we can beef up the services. I don't see that there's too much of a limit there. Yeah. Go ahead. Yeah.
I'm sorry. Continue.
No, and that's why I'm looking to once we bring on the nurse and potentially a public health aide to help with the nursing services and the linkage to enhance care management and community support and tracking the patients, right? I think that's a very important thing, is for us to track and not lose them. So I'm working on getting those positions filled. Yeah.
Okay, thank you.
Just to add, I just think the need in general for people living outside is greater than what any healthcare, like all of us together, can offer. There's just a lot of people living outside and a lot of needs. So I think there's always room to grow and expand.
Yeah, absolutely. I was just wondering if you had to turn people away. Certainly the outreach, just going out to where they are, is wonderful. Being in the parking lot is one thing. Being able to walk around and talk to people and say, how are you doing? And I know Alika was doing that on the river a long time ago, and I was so impressed with their work. It was amazing because these people wouldn't come in, wouldn't even go to the mobile unit. So getting out to them is pretty critical, I guess, it seems. But I was just curious if you had lines of people and waiting lists. And so I was, trying to get an idea of the usage of the services at that point.
Yeah, I think that I've been there for about a year and a half now, at the brick and mortar clinic for Loaves and Fishes. And as we have consistently been there reliably from 8 to 11:30 Monday through Friday, our numbers have continued to increase. And we do our best to see everybody as much as we can, but sometimes we do have to, like towards the end of the day, people will come in later, and we do sometimes have to turn people away.
Yeah, it's pretty amazing. I would say the majority of the folks are assigned elsewhere, but and even though it's not actually us going out to them, just by being at Friendship Park, they will come to us and on a pretty regular basis. We have some, so we have, just like Dr. Slack was saying, is that we have some acute patients, but we also have some frequent people who just feel comfortable with us. And like today, I feel like this is, amazing. A lady who's getting, everything together in her life. She just needed her employment physical form filled out so she can get a job. Her job starts on Monday. And I was like so excited to do the whole exam and fill it out and be like, you're healthy. And so it's, yeah. So even though it's not street medicine just yet, it's even the brick and mortar has been pretty amazing. And then, just as I was mentioning in the beginning, that van out in the parking lot, it's funny though, because there will be a line out there. Just sometimes they see the van and it beckons them. But I know that Dr. Slack and Landefeld have been talking about the river being maybe one of the first areas that we choose as our location. So hoping to finalize that soon.
Great, thank you.
And I saw a question out there about the youth. And so that's where we're partnering with public health, and Dr. Kassiri, and I don't know if Lynn is still on. I think they may be using the van. I know that Stacy Sayas has talked about potentially using the van to reach out to the youth and to provide some public health services over there. And I didn't know if you wanted to speak to that, but we haven't necessarily targeted that population yet. But I have had 1 or 2 conversations with our public health department, and maybe looking to work with them in reaching out to the youth later.
Yeah, I can add a few comments. Sorry, did I interrupt you, Dr. Osler?
No, please
just
go ahead.
wanted to say again, this is another exciting collaboration that we're working on with the Primary Health Center. And the way that we're using it for the public health side, apart from reaching out to the homeless with the nurse and nurse's aide, is being able to provide testing. We unfortunately are continuing to see an increase in STD cases, especially pregnant women who are homeless, who are on illegal drugs such as meth. And this has been one way that we're able to reach out to them and actually be able to provide the testing and the treatment as well. So very excited about the collaboration. Dr. Osolak also provides services at our STD clinic. So very glad to have her as part of the team.
Thank you. Yes, having rapid tests is a game changer. Being able to do it immediately really is great. And we have bifillin on site. So if someone is positive, we can treat immediately. And just to address one part of that question that Lynn asked, so we see everybody, they don't have to have an ID, period. Yeah, so we will see anyone who comes in.
And Steve, I think you've been waiting for a bit about the question you've got, and I don't know if you have more questions, but please.
Yeah, just a few things. First, congratulations on these efforts. Clearly, we need to expand services to people on the street, and this is a good effort. One of the things I do worry about has to do with documentation. And I know this is a problem, obviously, for our brick and mortar medical services, is that one group often can't communicate with others. And I'm just wondering, for example, if you want to partner with ELICA, which has a great program, or at least has in the past, are there ways to know that services that they provided on Tuesday aren't going to be duplicated by you on Wednesday? So that would be something worth exploring. The other question I had has to do with whether you'll be available for needle exchange, and also about accepting old and expired medications.
So as far as the first question about the information exchange, I know that county is working on something, HMIS, and hopefully, and I don't have all the information about that. And so, Tim, I haven't officially met you, hello, but you may have more information about that. But the fact that just specifically ELICA, now that they're on OCHIN, and our EMR is OCHIN, so we actually, it's been great. Yes, and we do have that easy information exchange. It is wonderful. So I can see everything that ELICA does, and ELICA can see what we do. And One Community Health, they don't have a mobile program, but they're on OCHIN as well. And so the fact, more and more people are in OCHIN Epic. So OCHIN is a vendor of Epic. And so we've been able to see much more than previously. Of course, there's a platform called Care Everywhere, which allows us to see those who are on Epic. And it's been useful, but certainly those who have OCHIN, it's been nice, and I'm looking forward to seeing what's happening with the HMIS conversations. As far as needle exchange, I don't, MK, you've worked with harm reduction a lot, and we haven't partnered yet with them, so you might want to speak more about that. Expired meds. So I always have to leave everything to our pharmacy director to make sure that we are in complete compliance with the Board of Pharmacy and what we can and can't do. So right now, as far as what we're going to do for street medicine services, we're bringing along over-the-counter medications. We've gotten the approval. Well, I shouldn't say necessarily approval, but the Board of Pharmacy has told us what is an appropriate way of being able to take those out with us. And it has to be under a provider's sort of, it has to take the medications out, dispense them, put the medications back up. So we're being very, very careful and following everything that the Board of Pharmacy says. We're hoping to expand and see what else we can bring on. But for now, everything apart from the over-the-counter we are prescribing. That is different than what we're doing at the brick and mortar. The brick and mortar, we are keeping a whole gamut of medications for things that for conditions that we see frequently there. And we have a process with our pharmacy director on how we log that and get reimbursed for that.
I can add a little bit more about the needle exchange. Right now, the way that it's done in Sacramento County, the approval has to come from the state. So we have 2 CBOs that are able to do the needle exchange. Sacramento County is not one of those, so we are not able to provide those services directly. Our role has been in tracking. We receive reports from the CBOs as well as from the state, and the state also checks in with us when it's time to reissue the approval to the CBOs. And then as far as expired meds, as Dr. Mishra mentioned, there are a lot of rules and regulations around being able to receive expired meds, and especially opioids. We do not have the safeguards in place to be able to receive those. So it's not one of the programs that we're able to have right now. And Dr. Oslak, I may have cut you off again. I apologize.
No, that was great. That was a better answer than I could have given. But I think like mentioned in the previous presentation, like people who the opioid overdose rates are significantly increasing in our county. And so ideally, the goal would be to partner with some of the community-based organizations who do provide the services like syringe access, Narcan, et cetera. And then all of the providers at Loaves and Fishes, I think all the providers at Loaves and Fishes are trained in buprenorphine and ex-waivered providers. Almost all, yeah. So the goal would be to continue to offer those services as well. And then one thing just related to medications, because I think this is important, because a lot of access to medication is a challenge and a barrier, is that with partnering with the public health aides, we were just talking to them yesterday about we do have a pharmacy at the primary care clinic. So an option would be to have, one of the public health aides there. We would be able to send in prescriptions. Medi-Cal would cover them, and then they can bring the medications to us on outreach at the end of the day. So it could be to folks. So having that kind of transportation, so not being able to give medications directly to people, but being able to have one member of our team pick them up is also an option to kind of decrease one of those barriers.
And I'll jump in briefly. I know Dr. Mishra mentioned information exchange. So yeah, county-wide, we're in the early implementation phases for our social health information exchange. I'm not sure if Janine Spotnitz, who's my manager over our social health information exchange, has been able to present to the FAB. If not, be happy to have her come to a future meeting. Broadly speaking, I mean, this is a really large scale project. We expect about 3 years implementation when all is said and done. In February, we're going to the Board of Supervisors to request authority for our implementation consultant. And so the overarching goals there is, how do we support efforts with CalAIM, with crisis response, with just our broad goals across the county. And our hope there is getting county providers, getting managed care plans. We're also working with SCOE on the schools, working with our correctional health on our incarcerated individuals, of how do we do linkages, case management, referrals. That system would interface with the major systems, including HMIS. And the idea being somebody would be able to provide their release of information to these set providers. That allows us to do warm handoffs, connections, do case management and follow-up. And you would be able to ideally get to a universal intake where we're not having to, do an intake at every single organization. They have the basic information. They might have specific, information that is the provider for whatever that service they'll be asking, but then they're just updating kind of that universal record. And then that person would also be able to, hopefully at the end of this, have their own community information record that they can take with them to support outcomes and care. It's definitely an ambitious project. There are a couple different ways that information exchanges are being rolled out across California and the nation. Sacramento will be one of, I think, about 3 counties that have this kind of a structure of an actual social health information exchange. So it's a really big lift for us, and it's an exciting project. Something that will need groups like the FAB and other advisory groups to provide us some input, guidance along the way. And that's where our implementation consultants will help as we build out an RFP for the actual technical vendors that are going to build the system for us.
Great. Thank you so much for all the context and background, and really just sprinkling a lot of new information. I know I learned a lot today, and hopefully others did too. Just want to add a couple of comments that were added to the chat. Phil commented on another resource for the disposal of old medications is Datura bags, which deactivate medications so they can be safely disposed of. And he put a link into the chat if anyone's interested in reading more about that. Doesn't look like we have any other questions. George, I think earlier there was a question you added at the end after Dr. Schmaltz's presentation regarding payers being interested in funding the project if they can demonstrate savings. And I think we touched on that. One of the challenges I think they mentioned was just there's a lack of continuity of information, and that's something that they're working on. Was there anything else you wanted to ask before we wrap up today's presentations?
Oh, thank you. Happy New Year.
Thanks, George. I think that looks like it's it. And we're actually coming to the end of our meeting time. So I just wanted to really just say thank you so much to our presenters today. I know FAB has a lot to kind of digest and sort of think about next steps on both of these. And we really appreciate you coming out here and talking through kind of what's working, what's showing up as a challenge, and sort of what are the next steps and the needs and collaboration with FAB. And we'll certainly follow up at a later date once we've had a chance to sort of come back together as the advisory board and think through some of the information we learned today. I wanted to open up any comments or questions from the public. I'm not sure if we have anyone on the line still, or any of our members, if there's any other sort of late questions or comments that folks would like to contribute. Doesn't look like there are. And as I mentioned, we weren't able to finalize the December minutes, so we'll vote on those at the next meeting. So unless there are any other questions or comments, again, just want to give a big thanks to all of our presenters, and also just acknowledge there's a big storm coming. I know everyone on this call is well aware. Please take care of yourselves, your neighbors, your community, those around you over the next few days. It's probably going to be a little bit rough out there. And we'll see everyone next month. And I think this meeting is adjourned. Thanks all so much, and we'll see y'all next month.